iron deficiency anemia part 2 video. So let's talk about the transferrin. I already discussed the transferrin is the transported form of iron. After coming back from the duodenal enterocyte, Fe plus 2 will combines with the transferrin and it transport to other organs. Okay, so this is the transporting molecule of iron. For example, if this is the transferritin, to this transferritin is a maximum chance for the attachment of 6 iron molecules. Means easily 6 iron molecules can attach to this transferritin. This is theoretically possible, but clinically only 2 iron molecules can attach to transferritin. So the percentage is 2 by 6 into 100 equals to 33%. Only 33% of the iron are combining to the transferritin, even though it is containing 100% of capacity to attach. So now let's discuss about the soluble transferritin receptor ratio. Soluble transferritin receptor ratio. Soluble transferrin receptor ratio. It is nothing but the erythrocyte activity in the bone marrow. Erythroid activity in bone marrow. Now let's move forward. Topic is hepcidin. Hepcidin is a very important topic because the iron present in our body is regulated by hepcidin. Now first let's decode the name hepcidin. Produced in hepatocytes. Hepcidin means inhibition. So it is produced by the liver and the activity is inhibition. What is it inhibiting? It is inhibiting the absorption of iron. Hepcidin increases, then iron absorption decreases. So this is the one point that you should remember. Hepcidin increases, iron absorption decreases. Let's discuss the mechanism. It's very easy. We already discussed about the mechanism of absorption of iron. So now let's discuss about the inhibition of iron absorption. Here hepcidin binds with the ferroportin. Then this hepcidin degrades the ferroportin, because of which iron is not released outside. So there will be decrease in the serum iron levels, which leads to the microcytic hypochromic anemia. And this is the acute phase reactant. So it happens during inflammation. So it's important to know the genes that regulate these hepcidin. There are majorly 3 genes that regulates these hepcidin. First one is HFE gene, second one is HJV. So these are useful for production of hepcidin. So in case they get mutated, then decrease in hepcidin leads to increase in iron absorption, which leads to the hemochromatosis, means iron overload. So these 2 genes are very important. So these are the clinical features you can observe in your patient if he is having iron deficiency anemia. First one is pallor because low amount of blood. Next one is fatigue. This is also because of low amount of blood. Next one is dyspnea. He may not contain appropriate amount of air supply and palpitations. So these are the normal symptoms you can see in anywhere, and the most important symptoms are angular stomatitis, cheilitis, and cholonesia. Cholonesia nothing but the spoon shaped nails. So these are the problems that we see in the tongue. Next one is Plummer-Wilson syndrome or Peterson-Brown-Galli syndrome. So it is a triad of 3 diseases. So first one is iron deficiency anemia. Second one is esophageal webs. Third one is atrophic glossitis. So these are the clinical features of the iron deficiency anemia. Next one, let's go to the investigations. So these are the major investigations that you should do. As usual, first one is CBC, complete blood picture, in which you can observe low concentration of hemoglobin, RBC mass decreases, and total leukocyte count also decreases. The platelets may be normal or increases. This increase in the platelet count is called as reactive thrombocytosis. Next, indices. All the indices will decreases. RBC indices like MCV, MCH, MCHC, all will get decreased. Next one is peripheral smear. In peripheral smear, you will observe some peculiar cells like microcytic hypochromic RBC. RBCs are smaller and more central pallor. Generally it is 1/3. Now it will be greater than 1/3. Next one is you can observe pencil cells. Remember this, like pencil lid is made up of iron. So in iron deficiency anemia we can observe pencil cells. And the third one is anisopoikilocytes, like different sizes of cells we can observe. Now let's discuss the stages of anemia. Stages of anemia. So these are divided into 3 stages: stage 1, stage 2 and stage 3. Let's discuss them one by one. In stage 1 there will be decrease in storage. So it is stored in the form of ferritin. So ferritin is decreased in the phase 1 of anemia. And second one is iron deficient erythropoiesis. Due to the decrease of the iron, erythropoiesis will decreases. Okay. And the third one is iron deficiency anemia. And all the peripheral smear identifications can be done in stage 3 of iron deficiency anemia, like microcytic hypochromic RBC, pencil cells, anisopoikilocytes. So, these are the findings that we can observe here in iron deficiency anemia. It comes in the stage 3. Now, let's discuss the treatment. The treatment that is given in the Robbins is iron therapy. First, so while giving the iron therapy, first we should monitor retic count. Okay. So, retic count starts to increase in 5 to 7 days. So, this is the first indicator that we should check in the iron therapy. Okay. For example, we have done the CBC peripheral smear examination. We came to know that it is iron deficiency, and we have started iron therapy. And after a week, investigation on iron and retic count should be done. If retic count increases, it shows that the iron therapy is working. So, we should continue the iron therapy. So, for example, a patient came to you. You diagnosed that it is iron deficiency anemia. So, you started him with iron therapy. So, after a week, he comes to you again. At that time, you have to check both the iron and the retic count in his CBC. So, if you find that his retic count increases, it implies that you have to continue the iron therapy because it is working. And you have to calculate the Menzer index. So, what is this Menzer index? It is nothing but the MCV by retic count, by RBC count. And it is very important to differentiate between the iron deficiency anemia and thalassemia. So, if it is greater than 13, it is iron deficiency, or if it is less than 13, it is thalassemia. So how to remember this? Iron deficiency anemia. The word is very big, so the index is also greater than 13. If we compare thalassemia to the iron deficiency anemia, the spelling is small, so it is less than the 13. If you want, you can remember it like this. So next one is, so this is all for today. If you not yet subscribed to the channel, please consider subscribing to the channel to educate you. This is K. Harshita signing off. In the next class, we will deal with the upcoming anemias.